If you look at the history of hair restoration, it started with something funny. Camel excrement, 5,000 years ago. In fact, if you look at all the stuff we do today on the internet, it's pretty close. The modern era, I believe, I give Deffenbach, a Prussian surgeon, credit. He transplanted feathers and hairs from animals. But the modern era began in the 1940s in Japan. And you know, in Japan, they have a shameful bareness to the pubic area because they do public baths. So pubic hair transplantation was the first modern grafting that was done. We probably look at the father of hair restoration as Norman Orentreich in the 1950s in New York with punch grafting. Obviously, today, we have more of a problem with looking at those early efforts because they are more grafty or pluggy or artificial. The modern era really began in the 1980s with Headington's seminal thesis on follicular unit grafting and understanding what is the follicular unit. If that is not clear to you, it will be in a moment. What happens with hair growth and loss? We have to lose about 50% of our hair before we can even recognize that there is something going on. So that's a lot of loss before we even recognize that there's loss to be had. What happens is the growth phase, the telogen begins to, the loss phase, the telogen begins to surpass anagen. That's one of the telltale signs that you're on the process of losing hair and you see more shedding than growth. Dihydrotestosterone, or DHT, effect on the frontal temporal hair is also important. And that's what Propecia or finasteride addresses to correct. There is not just a loss of hair. The hairs become wispy and thin. And those hairs are called vellus hairs or baby hairs. And those baby hairs are on the way out. So what is a follicular unit? This is the most important slide. If you don't understand this, you can't understand anything from this point forward. It's that our hairs are not grown in individual single hairs. They're grown in clusters of 1, 2, 3, and 4 hairs. And this is the standard of grafting, is using these follicular units and taking each follicular unit as a transfer unit or a graft. I want to introduce a more advanced topic. If you are going to start hair restoration, do not do this. This is a very advanced topic. It's multiple unit grafting. It is basically using 2 to 3 follicular units in one graft, in one single graft, and transplanting that. You say, well, is that a plug? Absolutely not. You have to know how to graft that well and select your candidate well. But you can get tremendous density in one session if you know what you're doing, and I can get tremendous density in one session. I'll show you my results down the road here. So what the multiple unit graft does is it provides a tremendously higher perceived visual density in really 1 to 2 sessions oftentimes. But you got to pick your patients carefully, and you've got to be able to technically execute that procedure beautifully. So what is a plug versus a mug? A plug is a terrible term. It was the large 16 to 20 hair grafts that were round, that were sticking out, that anyone could see from a mile away, that were positioned poorly. A mug essentially is a vertical or a longitudinal positioned graft that's much, much smaller and tightly interlocked behind rows and rows of follicular units. It is a completely different animal. And if you can't understand how to do this, it's okay. I just want to introduce the concept to you because it is an advanced topic, and most hair restoration surgeons don't know how to use mugs well. So let's start with just evaluating a patient. Patient comes into your office. What are you wanting to look at? The age is very important. You see a 20-year-old come into your office, you have an ethical responsibility to look at what your transplant is going to turn out to be in the next 20 to 30 years. You don't just transplant a low hairline and then watch everything will recede behind that. Be very careful and be very ethical. You've got to look at what the medical potential they can have in terms of treatment. And I only use FDA products. I'm going to talk to you about that in a moment. But also find out what they did. What attempts do they have? Hair system, because if they're using a hair system, that's a lot of hair that they get. And a hair system, by the way, is a toupee, if you will, for the common language. But that has a lot of density, and to match that density is a tougher order if they're used to that. So you need to find out where their expectations are. And you got to look at the rate of loss. If they're in a rapid progression of loss, you've got to look very carefully at that and find out, are they stable enough to transplant, and should you wait? This is just a very broad overview. It's not meant to go through all the nuances, just to introduce the concepts. So look at, and then do your physical exam like you would any other time. Look at that recipient site. Are they terminal hairs? Are they vellus hairs? Are they little baby hairs that are on the way out? That's very important. Look at how the pattern of the hair grows, and look at the extent of the hair loss in that area. And then, where are you getting the hair? From the donor area. Remember, the whole principle of hair restoration is to take hair from an area that even in the baldest individual, they still have enough hair, they won't lose that hair, and that hair gets moved to a zone that they will lose it, and it retains the characteristics of the donor hair. Now that may be obvious to a lot of you, but if it's not, that's the principle of modern hair restoration today. And look and evaluate that donor hair and make sure you have enough density, that the scalp is elastic enough, and that you look for previous scars and see if you can help that as well. There are really only 2 FDA approved products out there for improvement of hair loss. They do work well. I always say 70% of your result is from Propecia or finasteride, and it's easier to maintain. If you're not compliant, you don't get a result. Rogaine you got to use twice a day. Although recent studies have shown maybe even once a day is okay. But one's a topical minoxidil over the counter in the United States, and Propecia is a prescription pill that you take once a day. And here's the thing. You say, well, what is the role with medical support if you're going to do a transplant anyways? Remember one thing. Hair loss is a progressive disease. What I give you is permanent, no question. However, you continue to lose hair. I want you to regrow and stabilize your existing hair so that whatever I transplant looks even better. And that way you have fewer transplants and a fewer need for those transplants down the road. So how do you plan this? You know, this is the problem. You've got an ever-shifting canvas of loss, and you've got a limited donor supply. And you've got to figure out, based on calculations, that projected loss in the next 20 years. What I always try to help people figure this out is target your major aesthetic area. That's your hairline and your mid-scalp. That's the area where if you're sitting and talking to someone, that's what they see. The crown is not quite as important. Plus, if you develop a crown here and you got this loss, it doesn't look natural. Plus, the crown is progressive. So I usually don't like to touch the crown until I get that area stabilized on medical management for at least a year or 2, maybe even more. And that's based on patient compliance as well. They can stop doing it, and you got to talk about that. The hairline design. So many fake hairlines out there. I'm going to show you a lot of correction work, but the beginning is to find that anterior lowest point, which is a point of transition from the vertical to the horizontal plane. Anything lower than that is a good chance to have a fake result. So that is the lowest acceptable point. I even sometimes go above that. And sometimes I just do a little widow's peak to push that visual hairline down without necessarily making the whole hairline down. That way you conserve grafts and you plan for the future. And then the hairline, remember, what is a comb over? A comb over is someone combing temporal hair over to the center. So anything past the lateral canthus has got to be interpreted as temporal hair. You have to build it differently. So the hairline starts and stops at the lateral canthus. The lateral canthus are your lateral defining borders for your hairline design. I'm not going to go through all the ways to design it. But just as an idea, there's more of a bell curve suppressed look for someone with a slightly narrower head. So this is the level of artistry you've got to execute. When you're looking at someone, design a hairline that's going to match their face and their progressive loss. The other thing from a lateral view, the hairline design has got to be upward sloping in most cases. A flat design is quite aggressive, and a downward sloping is unnatural. So look at your hairline from all angles. That's important. After the hairline is designed, we shave the occiput, and that's the area we're going to harvest from. I love intravenous sedation. Because I have a surgery center, my patients don't have discomfort, and that's a rarity. If you do it on a local, there's discomfort. I mean, there's just no way you're going to get around that, but we don't have